it's Shay. Welcome back to the channel. I talk on this channel about all things nursing, beauty, and lifestyle. We gotta have a little kick in it every once in a while. But today, for my nursing bays, I am bringing you guys a nursing video. So, it is July. It is new grad season. It is, nurse-anniversary season, and basically guys, I had posted a telemetry video basically giving you guys the top diagnoses that I see as a nurse on the telemetry unit. Well, I did mention in that video that I am a neuro nurse, so today I'm going to be talking to you guys about the top diagnoses for an acute non-ICU med-surg unit. So basically, what type of diagnoses are we getting on a floor that's considered neuro med-surg? So if any of you guys are interested in this video, please stay tuned. If you want the telemetry version of this video, I will tag it up above, but make sure you watch this video first before you get into that one. I'll also link it at the end of the video, and make sure you subscribe. Okay guys, so I'm going to be talking to you guys, like I said, about the top neurology diagnoses that we get to my unit. If any of you guys are new to this series or haven't seen the other video before, I will give you a quick synopsis of myself. I've been a nurse for a total of, I think now it's 3 years. My nurse anniversary was a couple weeks ago actually, so yay. As always guys, I mentioned to you, this is a layman's term video. I really want to make sure not only am I targeting my nursing students who don't understand all the medical jargon at all, but just the general audience, because some people just want to know, like, what do you do? And if I start throwing out cerebral vascular accident and TPA and all these terms, people are gonna be like, oh no sis, I don't know what you're talking about. So I'm gonna try to use as layman terms as possible. Of course, if you guys don't understand anything, hit me in the comment box. And for all my medical people, please bear with me because we're gonna go on this journey straight layman, straight to the facts. Let's go. Alright guys, so for diagnosis number 1 that I'm going to mention to you guys is something that's very simple and we're not going to spend a lot of time on. Change in mental status. Change in mental status is one of those things that can happen for various reasons. Being the setting that my hospital is in, and also the fact that we do take care of a lot of older patients, I have to say that change in mental status is one of those things where you kind of have to rule it out, or basically get rid of all the stuff that could be the most critical in order to get to the source. For older adults, guys, you're going to see change in mental status a lot. A lot of it, not only, people like to always say, oh, it's dementia, it's dementia, it's dementia. But let's be mindful. Infection causes confusion. Infection causes confusion. UTIs, pneumonia, flu, those diagnoses like that, cellulitis, if you have any type of bacteria in your body, especially as an adult that is over the age of 65 and sometimes even younger than that, it will cause you to have confusion or moments that are not very rememberable. So automatically a patient comes in for change in mental status. What they're going to do in the ER is basically rule out stroke and rule out any type of neurological issue. So most of the time when they rule this out, if they find out that the patient has an infection or something like that, they will usually go to a step-down unit, not necessarily step-down, but a unit that can take care of this patient where they don't need the constant neurological checks. But my floor is trained to perform neurological checks every 4, 6, 8, and 12 hours. So if we need to keep an eye on this patient's overall neurological status, they will be coming to my floor. If we think that, okay, it's an infection, but there's something else underlying that might be neurological, they're going to come to my floor. So that's pretty much as plain Jane as I can keep it for change in mental status. Okay guys, diagnosis number 2 is going to be considered a seizure. So for any of you guys don't know what basically a seizure is, there is chemical balances in your brain. When sometimes these chemical balances are not met correctly, they will trigger a seizure threshold, or basically they will trigger the brain to have seizure-like activity. Seizures can be congenital, meaning they can be like you were born with a seizure disorder. They can also pop up later in life. And seizures can happen for numerous of other reasons based on other diagnoses. So, for example, epilepsy is the professional term for it. People can get epilepsy from alcohol intoxication when you're going through withdrawal, and that's what we see a lot. I can tell you guys, seizure patients, I see some of the youngest patients as seizure patients. Some people, for some odd reason, pregnancy can induce seizure-like symptoms, and I know some people who go on to have them the rest of their life and they have to take medication, and some people only had them when they were pregnant, and now they haven't had a seizure in like 10 years and their kid is like 9. So seizures can be, we are still, guys, learning so much about the brain. We have conquered in medicine every system of the body, but it's something about neurology. Not that we haven't made way, because trust me, we have made way, but there is a lot of things that still need to be learned. So seizures, basic seizure precautions is, of course, safety. Safety is the #1 priority. I don't want you to seize, hit your head on something, seize, choke, or things like that. So that's why these seizure patients are so important for our unit. They have to, according to our acuity, which can sometimes, get a little iffy. Y'all know I talk about that in my med surg video, but acuity can get a little bit iffy. But for our unit, we are trained to make sure we pay attention to the signs and symptoms that might lead to seizure. So the thing that I find hardest with my seizure patients, guys, is because a lot of them are young, I am not going to restrict nobody's mobility. So some nurses will be like, okay, you're a seizure patient. When was your last seizure? Oh, 4 hours ago. Don't get out of bed. I cannot tell a 28-year-old, don't get out of bed by yourself. Now, I will tell them, I need you to call before you go to the bathroom, because if something happens to you, I need to be there. I'll never forget a time in my nursing career where I was on orientation and we had a seizure patient, and we were in the other room with another patient who had another medical emergency, and the other patient was young and she got up to go to the bathroom, and I came in the room and she was on the floor. Seizure active. So you gotta push that Ativan, you gotta push medication that's gonna help take care of that seizure threshold and bring it down to stop the activity of the seizing. So seizure, the way I look at it, if I think about layman's term, is overactivity in the brain. So that's what's causing, between the chemicals in your body or the chemicals in your brain, there's some type of overactivity that's increasing your chance to have a seizure. So when that trigger, seizures are very particular. That little trigger, and all of a sudden the seizure can occur. So it's very important that when people come to the hospital, they get admitted to our floor. Of course, they need to have a neurology consult. Of course, they're going to get imaging done of the brain, the typical stuff, MRI, CAT scan, but also something called an EEG. It's basically taking pictures and waves of the brain to make sure and see if we can pinpoint exactly either what causes the seizure activity, when it occurs, or is there a certain point in the brain that is causing it. Like I said, layman's terms. So I'm not telling y'all I'm a neurologist, I'm not diagnosing nobody, but this is basically what we see in our seizure patient. Okay guys, the third diagnosis I'm going to talk to you guys about real quick hits very close to home, and we'll go into our last diagnosis. So I'm probably going to combine them together. So basically, I'm calling this a TIA. For the sake of the video, I know according to medical journals for the recent times, we are not supposed to call transischemic attacks or mini strokes a mini stroke, but for the sake of this video and for the sake of when I educate my patients, I still call it a mini stroke. So basically, a TIA is exactly what I said, a mini stroke. It's when somebody has stroke-like symptoms, but when you check their CAT scan or their MRI, they have not had a complete infarct or they haven't had a complete stroke because that area did not reach the brain in time enough to create a stroke. And that's the easiest way I can say it for people to understand. But when you have a mini stroke, your chance of having another mini stroke is 10 times greater, and your chance of having a real stroke is 5 times greater. So that's why it's important that even though these patients, like some people think, oh, I had a mini stroke, I went to the hospital, I was fine, the symptoms were 2 hours ago, you said it wasn't a stroke, can I go home? No, you can't go home, because your chances are greater. And most people who have a mini stroke, if things are not controlled, will go on to have a regular stroke within the next 24 hours. So it's very important that these patients get admitted to our unit. We follow a stroke scale to acknowledge their symptoms and to make sure they are not, increasing or progressing over time. We get this scale from the National Institute of Health. It's called the NIHSS. And that person should be assessed by a doctor in the emergency room with that scale, admitted to our floor, assessed by a nurse as soon as that patient comes to the floor with that scale, and based on that number, we assess that patient each shift. Now, I will tell you guys straight up, even though it's just each shift, I'm probably doing an honest NIH assessment on my patient at least 2 or 3 times throughout the shift, because a lot of the stuff that's in that stroke scale is also in your neurological assessment, and that most of the time when somebody comes in with those symptoms is either every 4 hours, every 6 hours, every 8 hours, and etc. So what are we doing for these patients? We're monitoring. We're making sure they don't have a stroke. Actually, we are taking into consideration their risk factors for stroke. So does this patient have high blood pressure? Does this patient have high cholesterol? Does this patient have, remember guys, I talked about those rhythms that are irregular on my telemetry video or my heart video? That is a risk factor for stroke. I told you guys, it quivers, it creates little clots at the bottom of the heart that can travel. That is what can cause a stroke. So people with those rhythms, they really have to be mindful, they have to be watched, and they also have to be put on medication to help not only control the rhythm, but also keep the blood thin, so even when it quivers, it is not building up and creating clots at the bottom of the heart. So it's a lot that goes into these patients, and people think it's just like, oh, I didn't have a stroke, so I don't know why I'm here. I hear that from like almost every patient that comes in for a TIA or trans ischemic attack, and we have to make sure they're mindful. 1, your chance of having a stroke is a lot greater. 2, your chance of having a stroke in the next 24 hours is a lot greater, and you really need to be put on either some type of medication or either an intervention done to make sure that your risk factors for stroke decrease, because this was your warning sign. This was letting you know, hey, I'm about to come full attack if you don't get it in order. Okay guys, so that leads us into the last diagnosis, which is a CVA, cerebral vascular accident. As you guys can see, I'm also a cardio nurse because I was about to call it a cardiovascular accident, but it's a cerebral event. And what happens is, like I said, you have a stroke. So basically there was some type of area or clot that traveled to the brain and caused damage in that area. Now it's so pivotal, strokes are so pivotal because strokes are so life-changing, guys. We have a whole order set. Like, as a stroke nurse, I can kind of tell you, like, all right, before a patient comes to my floor, is this order, was this scene, was that scene, was so-and-so scene. But the main thing I'm looking for at first, when I know I'm getting a stroke patient, you need to tell me how they rate on the scale, and you also need to tell me what their CAT scan said. So, was the CAT scan, does it show a stroke? And if it does show a stroke, is it what we call ischemic or hemorrhagic? Is it something that's constantly bleeding, or is it something that was a damage to the brain and that was that? Kind of like a blow. I don't want to say a blow to the brain because that makes people think of concussions and things like that. But that's the easiest way I can explain it without getting into all the technical terms. Now, that is going to base a lot off, once that CAT scan is done, it tells you a lot of information. 1, if they're coming to my unit. Because if they're coming to my unit, this stroke is not going to be taken care of with medication. Some people can get an intravenous IV that is going to go, and we call it a clot busting drug. It's going to go and get rid of that thing before it can attack. So they're not going to come to my floor. This is a stroke that has already occurred, that's already, you know, happened, and now we need to figure out, 1, to prevent it from happening in the future, 2, what are now the deficits, 3, it's hard to say how long these deficits are going to last, but how long do we think? And 4, what type of intervention do you need after that has occurred? It's so much, guys. Rehabilitation, physical therapy, occupational therapy. I have patients that came in, were completely fine now, can't eat, can't speak, has to have speech therapy. It's very, very sad. But what I can tell you guys, as a potential nursing student, as a potential nurse on this floor, you really have to be mindful of a neurological check. You have to know what, like, when you were learning in school how to do a neuro assessment, a neuro exam, your neuro assessment exams have to be on point. They have to be on point. You have to chart them in the allotted time so you can make sure you prove to people, I've been watching this patient all day. If there was a decline, it's in my charting and I, you know, communicated it. If there wasn't a decline, I still charted what was going on, but there was not a true decline. And I'm a neurological nurse. I know what to look for. So that's what's very important. also getting these patients, like I said, started on rehabilitation tracks. We have physical therapy, speech therapy, occupational therapy at our hospital in the acute setting, meaning for a temporary time. But does this patient need rehabilitation post-hospitalization? Once they're good medically, what do they need? So it's a lot that goes into taking care of a stroke patient. That stroke scale I mentioned before, you really have to be on your toes with it. If you are a new grad, I stress to people, do not stress. My first year and a half, and I still do it to this day, you know, we got the cow, the computer on wheels cow. I roll that right into the patient room, and I do that assessment going right down the list of what I'm testing for: ataxia, month and age, etc., etc., dysarthria, which means trouble with speech and slurring of words. I go right down that list when I was a new grad, and even till this day, sometimes to make sure I'm not missing anything or make sure I'm assessing correctly, I will wheel my computer in and I will hit those points. Now, I can tell you guys, I can easily do an NIH assessment probably in like 4 minutes, depending on the cooperativeness of the patient and what their deficits are. But when I first started, I'm telling y'all, I was rolling the computer in, taking my good old time, and you gotta do it because neuro is so important. You cannot miss anything when it comes to that assessment. Okay guys, so we have reached the end of this video. I've told you guys about the top 4 neurological diagnoses that I would get as an acute care nurse on a med-surg unit, not an IC unit or critical care. Like I told you guys before, if anybody's receiving those clot busting drugs, which they would have to meet a criteria to receive them, there's a time window, there's age, there's past medical history. There is a very thorough comprehensive exam that a MD or MP has to go through before we can say if a patient is eligible to get those clot busting drugs, because if they're not eligible and you give them to them, it can really have detrimental effects. But overall guys, I just wanted to come through. Like I said, this video is mainly for, I guess, my new nurses, anybody who's switching over from specialties. I know I've had tons of you guys saying, oh, I'm switching over from L&D to, you know, telemed-surg, or I'm switching over from peds. Congrats to you guys. I'm so happy. We're so excited to have you in our specialty, because like I told you guys before in my video I'll tag up above, people like to think that, you know, med-surg, tele-neuro is not a specialty, but it is. The skills you acquire make it a specialty. So not gonna hold you guys longer. Make sure you check out the telemetry video at the end if you haven't seen it, along with I'll tag the stigma of med-surg nurses, and of course make sure you subscribe so you guys can keep getting videos like this updated on a weekly basis. Please let me know down in the comment box what future videos you guys want to see pertaining to nursing, and I will see you in my next upload.